So it's with pleasure that I introduce our first presentation panel. And we've got Femi, and we've got Caroline, and we've got Regina, and that's all without my notes. I think I've done very well. Please put your hands together and welcome our team talking about cancer.
Thank you. All hear me? Hi, everyone. I'm Femi. I'm the Managing Director for North East London Cancer Alliance. So I'm just going to give a quick overview on what the Cancer Alliance is, just before I hand over to Caroline, who is the program lead for the North East London Cancer Alliance. Okay. Sorry, I thought it was automatic. Right. So just to give you all a brief overview of the Cancer Alliance, it's exactly in the title, really. We are made up of partners, providers, and health services across North East London. So the makeup is providers, the ICB, GPs. Everybody is a part of the Alliance that has an input with tackling cancer care across the system. So a lot of the work that we do is about preventing cancer, spotting cancer a lot earlier, and providing the right treatment at the right time. So we do a lot of the strategic work and working with all of our partners to try and drive the transformation and some of the work that's required to move our patients through the pathway as quickly as possible, diagnose them as quickly as possible as well, and of course the ongoing care that our patients require. So our work streams of work, or our areas of work, are split into programs aligned to the National Strategy for Cancer. So that's earlier diagnosis, diagnosis and treatment, personalized care, and of course we've got an element of operational improvement. But we know that if we improve pathways and we do all the things that we said that we're going to do, which is preventing cancer, diagnosing our patients as quickly as possible, then the operational improvement part just becomes a lot easier to do. Today we're going to be talking to you a lot more in detail about screening, breast screening in particular. So I'm just going to hand over to Caroline, who is our program lead she also has breast screen for early diagnosis.
Hi everyone. Can you hear me? I'll make sure I've got the mic in the right place. So as Femi said, I'm the early diagnosis lead from the Cancer Alliance, and I focus on screening and raising awareness of signs and symptoms of cancer. So first of all, we're going to look at some data, and I know that it's probably not very clear on this, but what this shows us over the year, starting from January 23 to December 23, the breast screening uptake rates across North East London. And it looks like we've done quite well in that we've got lots of green arrows pointing upwards. So that says that we've made an improvement in 5 of the boroughs over that time. 1 borough, Barking and Dagenham, has stayed fairly stable, and 2 boroughs we've seen a decrease. But they're all well below what they should be at 80%, and this is just for the whole population. So the next slide, again, is it's the same data, but just displayed differently to make it a bit clearer. So you can see the target, you can see that we're all below that, and you can see that if you look at I think it's the green line, is Redbridge, which has made a significant increase. I'm not quite sure why, but it's definitely something I need to look into. So moving on to screening by ethnicity. So the orange line here is the Bangladeshi population. And looking at North East London, you can see that it's 26, yes, it is right, 26% of coverage from the Bangladeshi women. There are some caveats with this data, is that it's taken directly from the GP systems. So it's all dependent on coding, and that's how ethnicity is coded and how breast screening is coded. But in the absence of anything else, we have to use this to look at the data, and I don't think it's far wrong. It is a snapshot at one particular point in time, but still, 26%, I think even with any improvement, is never going to get us near the 80%. So if you look at, just going to have a look in the next couple of slides at a breakdown as well of what it is for specific boroughs. So Barking, Dagenham, Havering and Redbridge is for some reason all lumped together, and that's at 33%. But when you go to like Tower Hamlets and Newham, you can see that there is a real drop, especially in Tower Hamlets. I mean, Tower Hamlets screening uptake is quite low anyway. But if we're looking at the Bangladeshi women there, it's 22%, which is incredibly low. Newham's a little bit higher, but not enough to make a huge amount of difference. But obviously, these are the areas where we have the largest Bangladeshi population in North East London. So what we're looking at from there is what is the problem. So we've looked at the data. The data tells us that screening is low, but what does that actually mean? And actually, why is it low? We know it's low, but why is it low? So we tend to make assumptions, and some of them are right, some of them aren't. So we make assumptions that language is a barrier, that women are embarrassed, they're afraid maybe of having cancer, but also of the pain of the procedure. So what that actually means for women in North East London, or for Bangladeshi women in North East London, is that if 74% are not screened, that's over 10,000 women that haven't had screening. So of those women, I did totally go off for a minute. So the consequences of that is that those that haven't had screening are more likely to be diagnosed later. And as a result of that, they're more likely to need more invasive treatments, and their outcomes are most likely to be poorer with higher mortalities. So there's definitely evidence of the links between ethnicity, late diagnosis, and the poor outcomes. So what we did, so we already had a campaign running called No Time for Cancer that we set up during the pandemic, and the idea was to sort of encourage women to come in, act on their letter when they got it, so they made sure they came in to have their screening appointment, but it wasn't specific to any particular ethnicity or target group, it was just generic. So we decided that the thing we had to do was, actually now we're out of the pandemic as far as possible, that we need to focus more on those populations that really need to increase screening uptake. And the Bangladeshi population was one of those. So with the help of Bashir and the Bangla Housing Association, we quite quickly got together a focus group of women from the community. This was led by Mobus, who's our creative agency, so they were the ones that facilitated it. And the idea of it was to get an understanding of what the barriers were, what was stopping women from going into appointments, or what motivated them, and then how to, from that, come up with some sort of campaign or intervention that would actually be really engaging and motivate them to come in. So the first thing they talked about was screening appointments. And really what came out of there was that they all thought that the information they got was very good, it was very clear, and it was, you know, that they'd all been for screening, all of these women, but they understood why some people didn't. So what they found as well, that what they needed here was, the first obstacle was that they needed a member of a family to translate the information for them. It was good information, but just needed to be translated because English might not have been their first language. The next thing that they were concerned about, and the major thing, was that they weren't sure before they went who was going to be doing the actual procedure. So they weren't sure if they might have a male mammographer, and that was a really big barrier for them. So they did appreciate, though, that, again, going back to language, that the nurses, they were English speakers, and they were very, very good, but they didn't always have translators when they were there. The other thing was the procedure. It was painful, as they thought. They found it painful, or more so than they thought. But because it was quite quick, once they'd had it once, it wasn't then a barrier the next time. They knew what to expect. And I think that was a thing that went through it. Knowing what to expect was really important. So here we have the barriers and the motivators. So there's, again, as we said, the uncertainty or fear around the procedure, and that is also about not knowing if they were going to have a male mammographer. And that wasn't a surprising thing. But what was more surprising, I think, was the fact they thought because they didn't have symptoms that they didn't really need to have it. So it's not really understanding the importance of going for the screening appointment and understanding that it would pick the disease up before they had any symptoms, and would therefore make it easier to treat. But they're also not making it a priority. And I think, as Fazana said earlier, it's not putting yourself first, not thinking about, because you're so busy with your life and looking after kids and things. So just not prioritising your own health. What did come out as the motivators, I think, mostly was around the message and having reassurance of people that they trusted. So if they've had family and friends that have been before, they're more likely to go on their advice. And just a reminder that anyone can get breast cancer. It's not anyone in particular. It could affect anyone. If 1 and 2 are getting cancer, it could be anybody. So, and also they felt that when they felt encouraged by their family and friends to put themselves first, to sort of feel that they could do that, that was when they were more likely to go. So this were just some of the messages they said that would increase people's participation. So saving yourself for your family, the importance of screening, again, putting yourself first, a real focus on screening and why it's so important, and on the impact of cancer and not having screening. And then to say, don't ignore your letter. If it's not your first language, then if someone can't translate it for you, there are translation services. So for us, the implications of that for our campaign going forward and how we're hoping to be more engaging is that it needs to be a really clear, simple message that can be translated easily. So what we found in the past with some campaigns that we've run or some leaflets that we've created is there's not always the same words in different languages, or some words aren't easy to translate. So it's about being really clear about that and making sure we're using words that we can translate easily. And then put everything in one place. So they won't use a QR code. They're not likely to visit a website. They're busy and they just want to see the information that they need. If they could have an explanation beforehand of the procedure and that reassurance that it will be carried out by a female mammographer, that would be really helpful. And looking at the images, what they need to see is people that they can relate to. So, and I think that's true of every target group that we work with. So it's being authentic, positive outcomes, a positive story being told, and just seeing people that they can recognise and relate to within with different generations, but in natural situations. So it feels like they can see themselves there. So there are some limitations. So the focus group was looking particularly at barriers to motivations and messaging to help us to design this campaign. And it didn't really address any of the more structural things and the practical and social reasons for non-attendance. So it might be that some women can't come because they can't get childcare, they can't afford the transport, or the services are not necessarily accessible by public transport. I think around here we've got scanning in Mile End, but sometimes people have to travel quite far to get the services. And then the other thing is, like, if we're thinking about what next, is breast cancer screening the only thing we should be prioritising? It's arguable really whether more people are picked up by this, or if it's more important to raise awareness of the signs and symptoms so women know what to look for. And that could help earlier recognition, especially in like younger women, because we're only talking about screening women over the age of 50. And then maybe sort of focus on awareness and encouraging the regular breast checks. So the last thing I wanted to do was just say thank you to all of the women that were in the focus group. I don't think there's any of them here, but just thank you to all of them. It's really important that we speak to people in the community, and I just want to I'm grateful for the time that they gave to join us and take the work forward. But I'd also like to thank Bashir and his team for helping us and pulling this together so quickly. It was very, very much appreciated, and we couldn't have done it without them. Thank you.
Hi, everyone. I know. I think I speak a little bit loud, so we'll manage to. I was just saying to myself, it just feels like going back to church and having the first sermon, reading to the public. But then, yeah, It's wonderful. I've never really had to see my face that broad on the screen before, so it's exciting to see. Anyways, I was just listening to Caroline speak, and I just realized that some of our findings kind of mimic each other. But then I've been told I have just 5 minutes to speak to this wonderful crowd. So let's see how far we can do this as quick as possible. Um, a little bit of a backstory. Um, Last year, around June, July, we received a grant funding from NEL as well as the Newham Council. So Newham Council kind of matched the funding that we received. And the purpose for the funding was for us to kind of run a co-design. Can you not hear me at the back? Okay. The purpose of the funding was for us to run a co-design program targeting 3 priority health areas. And the 3 priority health areas that we kind of settled on, I'm just going to stop here. The slides kind of are different from what I sent. I just don't know. There's a reason why that is. This is different from what I sent. Well, we'll just manage through. Is that okay? Yeah? So the 3 specific areas that we focused on was around mental health program for young black men within the ages of 18 and above, and also mental health program for South Asian women. And lastly, we looked at cancer screening programs specifically targeting Bangladeshi and Romanian women. You may wonder, how did we arrive at that? To be fair, it was a hassle. We did consider a wide range of quantitative data to be able to come up with a significant health issue that kind of stands out amongst others in comparison. But while we were doing that, it was quickly that we realized that we do have numerous health issues, but none of them kind of stands out to say, oh, this is very prominent or that isn't prominent. So based on that, we decided to kind of engage in conversations with primary healthcare providers. It was through that conversations and advice from them that we decided to focus more around areas with prolonged health inequalities. And that area which we focused on was a cancer screening program for Romanian and Bangladeshi women. So the cohorts that we kind of narrowed down our focus on was around breast cancer screening for Bengali and Romanian women above 50. We also looked at bowel cancer screening for Bengali and Romanian women above 56. And then the cervical cancer screening for Romanian and Bengali women are at the age of 25 and above. And I think questions would be why. So we realized that invitations to come and have your cancer screening are mostly sent to women within these age groups. That's the reason why we focused around that. So for the project, our main aim and our objectives was to tackle health inequalities through conducting co-design or co-production with residents. We also wanted to target communities where engagement and participation, especially around cancer screening, was very low and has persistently remained low. We also wanted to increase the willingness and the urge to accept or uptake the cancer screening programs and services that were provided for them within their community. And most importantly, we wanted to identify those barriers that have inhibited the take-up of the services. In the delivery of this project, we partnered with a voluntary organization called Catch 22 Community Service. I guess it's a very familiar name, because sometimes when we go for presentations, we mention people, oh yeah, we've worked with them. So I don't know if anyone has worked with them, then yes. They were our main providers for these services. And through them, we're able to get a targeted team group to help in the delivery and engagement services. Basically, the teams that we put together were people who looked like the community that we were hoping to engage with. They were very fluent in Bengali, and they're also fluent in Romanian. And we also aimed to target our residents in specific and strategic locations, like the GP centers. We went to market centers where we kind of put up a stall so we can engage with women who visited the markets very, very often. Now, our aim was to ensure that our engagement with people was within an environment that was very familiar with them, so they can feel very at ease to communicate with us and also interact freely. We also realized very quickly that the questionnaires that we had put together was not only too much and cumbersome, but it was also difficult for them to read and understand. So thankfully we had a team that were very fluent in speaking local dialects. Then we provided face-to-face translation services to enable people understand the questions and be able to provide answers as well. The questionnaires were also translated in different languages within. Listen. So I realized during this project that when I thought we can only translate into Bengali, there were also other dialects within the Bengali communities that came up. So that meant also that we needed also to pay attention to those people so we can meet the different needs that arose. We also offered information programs through that in form of signs like cartoons, diagrams, just so we can encourage understanding and improve knowledge. I'd mentioned 8 places where we visited. So this table just shows how many visits we had in each of the places and how much engagement we had for each of the community. So I'm just going to kind of skip through quickly. In terms of the findings that we gathered for the project, it was quickly that we realized that one of the issues that had inhibited people from taking up the services was because they lacked confidence to be able to identify some of the signs and the symptoms of the disease. Only around 20% of the participants were acknowledged the fact that, they could actually tell how they could identify simple issues of, say, breast cancer. Some of them didn't know how to tell when they were having issues around bowel cancer. So I think that area was an area where we kind of identified a gap and we needed to do more work around that. Okay. There were significant misconceptions around the relevance of cervical cancer screening. We had a focus group where women were brought together to discuss, and we wanted to identify reasons and barriers also with this group. And it was there we identified that they didn't have enough knowledge around the reason why cervical cancer screening was taking place. They will attend the invitation to come and take up the screening test. However, they said they did not know what happens afterwards with the test and why they were being called up for the cervical cancer screening. In terms of cancer being discussed amongst family members, that was also a very big barrier. We identified that within family members, especially within the South Asian community, topics such as cancer were seen as a taboo. And that was because people quickly believed that if you have cancer, you might not survive from it. So people felt it was ill luck to discuss issues like that within the family. So even when people tend to have pains, around, say, for instance, their breast, they keep it to themselves rather than share it. But on the contrary, on an opposite phase, I would come to that later, it just also plays a role to see that family members also encourage people to also take up the services. We also had around 60% of the respondents face this difficulty speaking to healthcare providers. That plays more into language barriers. Now, this was very prominent among elderly population, where we find that women who were within the ages of 60 and above, although being presented with health information that were translated in their local dialect, they were unable to actually read and understand it. So there was also a need for us to make provision for translators within the GP sector. So this is basically demographics of people within the age groups that took up engaged in the program, and how the participation was recorded. So in terms of recognizing signs and symptoms, you could see here, for Bangalian women, they are represented in orange, and for Romanian, they're represented in green. A large majority of around 94 agreed that when they find lump on their breast, it's also a sign of breast cancer. However, in contradiction, we had around 69% of the Romanian group who identified that. So this is one part of the data that kind of stood out for me. In terms of reasons why people would participate in the screening services, for the Bangalian group who were represented here in orange, you could see that supportive and cultural sensitivity was very low. And that was a bit different when it came to the Romanian group. They wanted people who looked like them to be part of the healthcare service, delivery services. And then if you look closely, you see where it says the clear accessibility to information and about screening. The Romanian women were very familiar with the kind of information that we're already providing. However, in terms of the Bangalian women, there was a very high percentage of difficulty in understanding the information that we're already providing. And I remember when I talked about the support from family and friends, down there you can see 49% of Bangalian women would rather go for a screening if they are being referred to by their family and friends. So although in the first slide we did see that it was a taboo, but if somebody within the family takes up the services and comes home and gives a positive remark about the service, it was also an encouraging or a boost for people to be encouraged to go and participate in it. And that also shows in a way that we need to make every contact count, and ensure that the services we provide within the visit of each of the patients we give them sort of a positive experience, so that when they leave with a positive feeling. So that would also boost the referral. So what influences the decision to attend screening? A large majority of both populations, both Bangalian and Romanian, said once the screening services was provided by either a GP or a gynecologist, that would motivate them to take up the services. It was also identified that people valued information or invitation that was given directly from the NHS. However, issues around people, I know I have to attend, but then the appointment time does not fall in the time in which suits me, because many of the people who we kind of engaged with were in sort of a job that does not necessarily run like the normal 9 to 5. So sometimes the appointment time may not necessarily suit with their own timing. So those things kind of deterred them, and in some cases it also encouraged them because they were available to attend the test. So we had issues around language barriers. For Bangalian population, around 76% had language as a barrier in terms of communicating with health service providers. Now, in terms of the focus group that was put together, I would swiftly to the next screen. We could see some of the feedbacks that were given to us. Some of them said, we know the test of the cervical screening is needed, but we do not know why and what it's used for and what happens afterwards. We are not well informed of the process and what will happen during and after the screening. So this is just to give us a highlight of some of the words that the women shared with us during our engagement services. All right, these other slides are just in-depth and did not necessarily have to do with the conversation that we're having here. But I hope I have been able to transfer the message to you guys, although the slides were a bit different from what I sent. Thank you very much.
So while the slides are loading, I can just sort of give a kind of overview and a scene setter. So I am Susan Eldon. I'm the NHS London public health consultant working on immunization, and my colleagues Jackie and Joe will be presenting. I wanted to just give a quick scene setter about vaccination across the life course. When you see the slides come up, hopefully you can see that the point. Do I need to load them, or are they loaded? Ah, okay. Great. Okay. So we know that vaccination is not just something that happens once or in the winter season, but it happens about 15 different occasions throughout the life course. So very, very important. And this is definitely another example of speaking to the choir here, because having talked to most of you at the lunch break and the tea breaks, you're very familiar with the communities and some of the barriers to vaccination. But it's just to reinforce that vaccination isn't something that happens once, it happens throughout the life course. It's an offer, it's not mandatory. You might be able to tell from my accent, I'm originally from America. If your child goes to school in America, in the public school system, it is a mandatory expectation that they vaccinate. Here it is an offer. We are fortunate to have a health system that provides free at the point of care. But again, that is something that not everybody takes up. And so it's something that we have to, it's something I feel quite proud of, and I think that we all should take pride in the system and the service that we have here, but it's something that we can't take for granted. And it's something where we need to actually work harder to make it work for our populations who don't get vaccinated, who miss out on vaccinations. I just want to show a little bit of how what that looks like on vaccination over time. Is we know that we like to have about 95% coverage, particularly on childhood immunizations. That protects against outbreaks. Some of you may know we've had some measles cases here. We've had some measles outbreaks. It has hit particular communities quite hard. It's very devastating for parents. 95% coverage protects children and families against that. In England, our coverage is dropping. It's dropping over time. And we also have gaps, and that gap is even more pronounced in London. And so it's not just the coverage declines that we worry about, but it's also the people who miss out, the communities who miss out, and the children who miss out. And so that's what we wanted to talk about today, and to hear from you is how can we get better at reaching people who miss out. Now, similar to breast screening and a lot of the other things that have discussed today, we know that the leading factors that, so who you are and where you are affects the kind of health services you get. And I think that sums it up in a nutshell for vaccination as well. So we do know that children that come from more deprived communities, we know that certain ethnic groups, whether that's language or cultural barriers, do not have the same level of protection and coverage with vaccination. And so it's really important that for example, if we know, for example, in Hackney, for example, it's about 50 MMR coverage, something around 65% from the last cover data. Now, that data isn't perfect, but what that tells us is that a large proportion of the population could, be hospitalized with measles or worse. I want to sort of end on a bit of a more helpful note is what do we know about London's Bangladeshi community? Particularly for childhood immunizations, when we put together the image of what it looks like from ethnicity and deprivation, actually Bangladeshi communities in Tower Hamlets are bucking the trend, and they are more vaccinated than other ethnicities. And I just think that that's a cause for us to celebrate a moment here in the room. I think by and large, because of all of the dedication of the services, the NHS, the council, the voluntary sector groups, all of the people here in this room who work so hard to protect those communities, when we see that effort going in, actually people listen, people want to be heard and felt and understood, and that makes a difference, and that shows up in our vaccination coverage. And that's why we haven't had the widespread measles outbreaks. That's why we have been able to contain polio, and that's why things are largely working, but they're hard-fought gains. And so I wanted to thank everybody in the room for this. And now I'll hand over to Jackie to talk about adult vaccination.
Good afternoon, everybody. My name is Jacqueline Walker. I'm the Operational Director for COVID and Flu vaccination programmes for the London region at NHS England. And I'm going to focus on a couple of slides just covering COVID and flu vaccinations. And just to sort of focus on what the data is telling us. And you'll see, I don't think you'll see it very clearly at the back, so I will reference some of these figures and just point out the quite stark differences in the uptake we see amongst the Bangladeshi community compared to the white British community. And you will see there that for the IMD1, which is the most deprived decile, for the white British population, this is for COVID vaccination, there was an uptake in spring, in our spring campaign, of 39.1%. For IMD1 in the Bangladeshi community, the uptake was, just about read it, 9.6%. So huge, huge difference. And when you go to the IMD10, which is the least deprived decile, the white British population had an uptake of 64%, whereas the Bangladeshi community had an uptake of 30%. So a huge, huge difference that we need to recognize, we need to note, and together do something about. We do see significant variation across London for our Bangladeshi community. So we only see 8.1% uptake in North East London in our most recent COVID vaccination programme, which is so low, compared to 24.9% in South West London. So quite marked variation. And we know we see a lower uptake where we have the higher levels of deprivation, and particularly in Tower Hamlets and Newham, where we have our largest number of Bangladeshi population. Also for flu, so we do feel in London that we do a bit better for flu than we do for COVID, for quite a number of reasons. And for flu, we're still lower than the national average, as we are with COVID. A little bit higher uptake amongst the Bangladeshi community and other communities, but still not where we want it to be. And also what we have to focus on as well is the level of risk. So we know our COVID and flu vaccination programs are open to those who are eligible, who are at greatest risk of serious disease and death from these diseases. And to note, the Bangladeshi group had some of the highest age standardized mortality rates for COVID-19. And during the third wave, not even the first wave, the third wave of the pandemic, mortality rates for Bangladeshi men were 4.43 times higher than the white British population, and for women it was 5.23 times higher. So much greater risk and a lower uptake of vaccination. And although adjusting for vaccination status, and looking at the reduced mortality risk associated with that vaccination status, there is still evidence suggesting that despite that lower vaccine uptake, that there is higher mortality. And that suggests that there are other factors alongside vaccination, so socioeconomic inequalities and health disparities. And we've heard a lot about that earlier on from the speakers this morning. So what are we actually doing at the moment? So a national vaccination strategy was published within the last year. You might well have seen information on that. And we've also published a London vaccination strategy. And our London vaccination strategy is very much aligned to the national strategy. And in those strategies, we've referenced what we need to be doing. So it's about improving access, more joined up prevention and vaccination offer. So people are telling us they want to discuss their broader health and well-being needs, not just talk about having a jab in an arm. So we need to recognize that community insight, that information we've got now, how are we going to approach things differently with our communities? And also improving understanding and motivation. So making sure there's the right education, the right awareness, but that those conversations are approached in an appropriate way, that we're building trust and confidence. Again, we've spoken about that this morning, and that those communications are culturally sensitive and tailored to meet people's needs. And we've spoken about partnership and working together. Absolutely think that is key. And that's what today is all about as well. We need to come together. We need to work in partnership. We're stronger together, and we all have a responsibility to do that. So our strategies absolutely outline the importance of that joined up collaborative working, but that's not just NHS partners, local authority, colleagues, Directors of Public Health. This is about working in partnership with our communities. And having that community insight on what is going to work best for that community in relation to our communication strategies and our delivery models. Quite recently, over the last sort of 6 to 8 months, we've set up some vaccination and screening groups. They were initially called vaccine steering groups. Now vaccination and screening, recognising that wider health offer. These are being hosted by NHSE London. And a driving force for our VCSGs is actually our Assistant Director of Vaccine Equity role, which Riyadh is currently working into. And this is about bringing partners together, clinical voices, people from communities who can work with us and with our statutory partners and with voluntary community, social enterprise, to work together on what interventions do we now need to take forward. We've come a long way, and there's been some great work that's happened, but we all recognise we need to do more. And this is about that approach of trusted voices, trusted leaders in trusted places. We need to recognise that and adapt the way we reach out to people in line with that approach. And as I said, it's about building trust and confidence. So we're really keen to hear from you today in the discussion tables and during the Q&A, how we can work together to make further improvement and recognising what the data is telling us and what else we need to do. Right, I'm going to hand over to Jo, our Senior Communications and Engagement Manager.
So, hello, good to be here this afternoon. So, co-produced communication. Co-production to me is an absolutely essential part in reducing health inequalities. Working with people, and emphasis on the word with people that have the lived experiences, genuinely listening to them, which I have to say, for someone with X amount of years comms experience, in the beginning, you're desperate to say, no, it would look better like this. Don't do it. I had to learn very quickly, they know best. I don't. I'm just there to facilitate it and bring it together. I've worked firstly with the London Bangladeshi Health Partnership, hello Riyadh, hello Charmin, since I was in the Legacy and Health Equity Partnership. I'm now part of the London Communications team and also part of, I've got loads of colleagues, it's wonderful. I'm also part of vaccination and screening. And co-delivery as well, we've discovered. This is where what Jackie said about the trusted voices, trusted places, trusted leaders. Having them actually be able to get the communications out rather than it coming just from me has proved to be incredible. So I just want to say co-production to me is a process of working together, which I feel should be respected. Now I know there's a long way to go still, but I'm hoping if we all work together, and by that it means I really do want to hear from you. If I get something wrong, like if NHS Comms has got something wrong, tell me. We'd rather get it right, we'd rather reach to you. So as you gathered, we've done co-production from the start, right from the inaugural, the inaugural event that was held, and we're still going. So thank you very much to all of you. So we've worked on here, I just want to give you a couple of examples. This is the COVID and flu vaccinations. We put it out on the Asian Radio Star. We put it in Bangladeshi Post-Muslim News and Asian Standard. And as you can see, there might be a face or two you recognise. This is where we're heading towards. We want real people. And I'll say thank you to Galina as well, who is part of the Romanian VSG, who has put herself forward. These are European, VSG, because it makes a huge difference. And the audio cards that were produced by Riyadh and his wife, that's Riyadh's dad, that's Riyadh's son. So, you know, and they went down well. And what I can tell you, I haven't got the slide, but we could see an increase in uptake. And that's the first time we'd ever tried to monitor it. But we could see that people were listening to people from their own community. MMR, I'll quickly go through that. It's the same thing. We worked very hard. We concentrated on the non-port gelatine part of MMR, and we got that all out there. It was very, very well received. So what's next? As you can see, we're doing some street advertising. These are going to be placed near mosques, South Asian cafes and food stores, and you'll see those go out there during October, November. And in line with what Jackie was saying, if you look at the community media, the Bangor Post one we did there, with keep you and your baby safe and healthy, it has to be more than just get your one vaccination, get whooping cough, you know, get COVID and flu. We put them all together, and that's now how we're trying to, and I hope succeeding in, looking at how we communicate with audiences rather than trying to give the hard sell of have a vaccination. So how can we work with you to make sure health communications work for you? It's really important, and that's why I'm happy to be here today. Thank you.